everyone. Thanks,
Hi.
Professor Saha and rest of the delegates from across the world to joining us. So it's like greetings from HCG team Bangalore. Good evening, everyone. So it's a pleasure to welcome everyone for the third lecture on the neck module of the head and neck webinar series. And today the topic of discussion is the current controversies in the management of neck. And it is our immense pleasure again to have one of the senior professors who has contributed immensely in the management of neck, that is Professor Anil D'Cruz. We are really thankful for sparing his time to educate us on this management of neck. So to moderate this session, we have Dr. Vishal Rao, Chief of Head and Neck Services at HCG Hospital, Bangalore. So over to you, Vishal sir, for moderating this session. Thank you, sir.
Thank you. Thank you, Akshay. Anil sir, thank you so much for sparing your time and joining us. We value this, and I'm sure all the participants are eager to start the discussion and listen to you. So without much ado, I'm going to get the ball rolling. I just want to give a very brief introduction to sir. Dr. Anil D'Cruz holds the current coveted position to be the first Indian president for the UICC, the Union for International Cancer Control. He is also been the former director of Tata Memorial Hospital, and currently is the director of oncology services for Apollo Hospital. I would require a separate session of 45 minutes, which Akshay didn't give me to introduce him. Otherwise, I was telling them we can start at 3 o'clock, and I can introduce sir fully. So I think I'll, with this, get the ball rolling for Anil sir. He's been our guru, he's been my mentor, teacher, and I owe a lot of my work to him. So with this, I think I will invite sir to share his slides. So we've got the sharing option for you. You can just start sharing the slides with this, sir.
Okay, so I just click on share screen, right?
Yes, sir. Yes, sir.
Okay, lovely. Where does it come now?
It's on the bottom. It's a green colored in the bottom
panel.
I
got it. Yeah, has it come?
Yes, yes, sir.
Oh, lovely. So thank you, Vishal, for the kind words. Thanks for having me to do this topic on current controversies in the management of the neck. It's something that's been very, very close to my heart. It's a little difficult to speak in front of so many formidable people. I kind of saw the faces as they kept springing up, but I'll try to make an effort to do the best that I can. And it's really a proud moment for me to see all that you have done. I recollect you being with us more than a decade and a half ago, and to see from those days to where you have reached is truly a matter of pride for me. And all I can do is wish you still better days ahead in your professional career. So as I said, I'm going to discuss current controversies in the management of the neck. Why doesn't this go to the next slide? Okay, here it goes.
No, you have to just play the presentation, sir. It's in the view mode. You can just click the...
Okay, lovely. Is that better now?
Yeah, much better.
Okay. So, cervical metastasis is the single most important prognostic factor, and that's something known to all of us. The moment you have a node positive, you have decrease in survival by 50%. You straight away go to a minimum of stage 3. A further 50% reduction if there is extracapsular spread, because it goes now with the new staging into what's known as N2. And we all know, as we treat head and neck cancer patients, that regional failures are a very important cause of mortality and suffering for the patient. So really appropriate management is paramount in the management of these patients. Now, the last decade and a half has witnessed changes in the management of the neck. We've understood the biology of nodal metastasis in a better way. There have been advances in technology. There's imaging, sentinel node biopsy, various other advances in technology that helps us manage the neck. we've shifted in the last decade and a half to non-surgical management for larynx, oropharynx, and hypopharynx. And surgery, which used to be the prime modality for neck, is now kind of reserved to salvage in these situations. But I think the most exciting is the emergence of new data, and that's what drives all of us. You can have technology, but if you don't have data, there's always debates and controversies, and then we keep arguing till the cows come home. As I said, this has been an area of my work, and I put up a couple of a collage of the various studies that I've been very proudly associated with over the last decade and a half when I was at the Tata Memorial with a whole group of illustrious bunch of a head and neck disease management group. And that has led to me being invited on two big panels. One was the ASCO guidelines for the neck that was out last year. And for the youngsters who are listening in, if you want to know how to manage the neck and squamous cell cancers of the oral cavity and oropharynx, Google the ASCO. I think it's March of 2019, and you'll find the first publication. It's very, very evidence-based. I may not agree with everything said there, though I'm an author, and I'll go along and tell you why. And then there is the other consensus that I contributed, and that's for the sentinel node biopsy in oral cancer. And that again was out late of last year. And these two make very good reads and would keep you up to date with current management of the neck in head and neck cancers. Now, what are the controversies? If I had to divide it, I would divide it into the N0 neck, that's the clinical radiological node negative neck, the extent of neck dissection and the role of the sentinel node biopsy, the neck in the chemoradiotherapy setting, and then there are other controversies of adjuvant treatment, imaging, the current role of molecular gene expression classifier. But Akshay told me these are being covered in other modules. If there is time, we can discuss them. I'll also be happy to take questions. And I'm just going to focus on the first three and focus mainly on the controversies surrounding these three broad headings. So the N0 neck, that is clinical radiologically negative. Now, this has been a debate for more than 5 years. You get a patient with a small lesion like this that you can excise per orally. Doing the neck is a second procedure. And that resulted in two schools of thought. The wait and watch group that observed patients. If they failed, they did a therapeutic neck dissection. And the proponents of this school said that it avoids additional surgical procedures and it's a neck dissection, saying that you get better control and survival, and it's a single stage procedure. Now, a couple of slides may be a repetition of what some of you all have heard, but I also gather there are a whole load of students, and if I don't put that data in, they will not be able to follow the rest of the discussion. So some of y'all seniors, please bear with me. But it's also a good idea if y'all revise some of these figures, because numbers we keep tending to forget. So for 5 decades, people fought. Some wait and watched, and some did the elective neck dissection. Sometime in the early 2000s, there was a consensus, there was a kind of a review on how the neck is managed. A US survey, 763 ENT surgeons, you can see disparity in how they were managed. They say the younger guys opted to do the elective neck dissection. Some of the older guys and people in academic institutions would observe. People in private practice would do elective, and there was a lot of hue and cry about the figures surrounding this kind of data. Exactly the same in Europe. 50 hospitals, 39 responses, no uniform therapeutic concept on how to treat the N0 neck. So in 2004 then, with all this confusion in literature, we embarked on this randomized controlled trial. Very, very simple trial. Basically what was done was 1,281 T1, T2, N0 patients were randomized. 596 were randomized, At the time of analysis, we analyzed 500 because the Data and Safety Monitoring Committee at the hospital felt that we should analyze it because they did observe some differences in outcomes. At that time, there were 243 elective neck dissections and 253 that were in the wait and watch arm. Now look at the outcomes of this study. There were 81 relapses. There were 81 relapses in the elective neck dissection arm, 146 in the therapeutic neck dissection arm, translating to a difference of 23.6% in the disease-free survival with a highly significant p-value of 0.001. Look at the overall survival. There were 50 deaths in the END arm, 79 in the wait and watch arm, translating into a 12.5% difference in overall survival, 80% if you did an END, 67.5 if you did a TND, with again a highly significant p-value of 0.014. Subsequently, there have been 8 meta-analyses looking at the same topic. And this is after a randomized data, just to drive a point home how hot this topic is. 8 meta-analyses. Now, I've made a slide of these 8 meta-analyses, and I have to thank Dr. Richa for helping me to make this Excel sheet. So if you look at these 8 meta-analyses subsequently published, looking at various type of studies, like RENS only looked at the prospective studies, some looked at prospective and retrospective, and a fair number of patients across different endpoints, focus on the last column, all show a benefit of END, whether it decreases neck recurrences, whether it improves survival, whatever it does. And why was this debate for 5 years? Because the published literature had small number of cases. So no one could show a difference in overall survival. Everybody said trend towards this, that, and the other. But here we have 1 randomized trial, 8 subsequent meta-analysis, driving a point home that the elective neck dissection is what you must do in your patients. And that's how it's come into the guidelines. Here are the ASCO guidelines, recommendation 1.1a, and you can read for CT2 to T4 N0 elective neck dissection is recommended. For patients with T1 to N0, ipsilateral neck dissection should be performed. Alternatively, they say there is an option for close surveillance. And that's why I said, I may not agree with everything that's said, but I'm not going to get very passionate about it, but I'm going to reason with you all with science as to whether the second part of this guideline really holds true. Now, it must be remembered that all guidelines are not gospel truth. Consider evidence, use rationale, look at the biological basis, and most importantly, logic and common sense in what you do, and be safe for your patients. So let's look at this and the controversy in light of elective neck dissection being the standard of care. Could we avoid neck dissection in any group of patients? So the ASCO guidelines said in T2, you have to do. In T1, you may have a role of observation. Here is the second large randomized controlled trial looking at exactly the same cohort that we did. In fact, in the SEND trial, which is a UK trial, the lesions were less than 3 centimeters. We took up to 4 centimeters, full T2. They took up to 3 centimeters. They stopped the trial in light of the trials of our findings. At that time, they had randomized 250. They looked at 346 observational patients across 27 hospitals. Occult nodal metastases were found in 19.1% of T1 and 34.7% of T2, something similar to our trial. And look at this, the intention to treat. disease-free survival was in favor of doing the neck. Second, large randomized control trial. More importantly, benefits seen even in T1 tumors. So I go back to the ASCO guidelines that in T1, there is a role for observation based on the Netherlands study, and we'll take that study again in a little more detail. Randomized evidence from a developed country, the UK, high level of care, T1 lesions also benefit with a neck dissection. Second, could imaging triage patients who need not have had a neck dissection? I'm quoting results from the SENT trial, which is the Sentinel European Biopsy Trial. 400 node biopsy. Look at the incidence of node positivity. 23% have node positive. And I'm going to show you the next slide, where for years we believed that more than 20% positive, there's a detrimental effect and you cannot observe the neck. So I repeat, European trial, ultrasound huge in these countries, 14 European centers, 415 patients, CT and or MRI. Look at the features that they used, even less than 1.1 centimeter. And then they had a 23. So really imaging, despite how rigorous you are in imaging, 23% will come positive, and we know the magic figure of 20. So T1, not good from SENT trial. Imaging, not good from the SENT trial. Could we then avoid in thinner tumors? And we know, and here is a classical paper by Ron Spiro from Sloan Kettering. Dr. Shah will get a deja vu seeing this. This is from Dr. Shah's book, but the work originally came from Ron Spiro, and various others have shown this as well, that as you go thicker, the incidence of metastasis increases, and so also mortality. So if you have a tumor less than 2 centimeters, the risk of metastasis is 7%. And we've been told that if it's less than 20%, you don't need to do the neck because it won't translate into a difference in mortality when you look at an entire cohort of patients. Is this correct? Look at our forest plot. It kind of bears up with this because if you look at depth less than 3 millimeters, those of you all who are not familiar with the forest plot, this is a subgroup analysis of our N0 trial. All those boxes on the left are elective neck dissection is better. This side, therapeutic neck dissection is better. The bigger the box, the more the number of patients. So look at the less than 3 millimeters. You can barely see the box somewhere here. Out of 500 patients, they were about 71 centimeters. And really, there may not be a benefit of elective neck dissection. And in our paper, we wrote as well that this is a matter of future debate and research. But I have certain thoughts on this, which I could share later. And I don't want it to be only on this. But how do you know depth before you operate the patient? Remember, depth of invasion is from the basement membrane of the adjoining mucosa. Basement membrane is not seen on imaging. If you pinch a lesion, unless you're really God's gift to mankind, I'm not sure your fingers are accurate enough to assess depth. And remember, this is going from 3 millimeters to 4 millimeters. I can understand from 3 millimeters to 8 millimeters that 1 millimeter can make a difference and increase the neck node metastasis percent upwards of 20, and you'll compromise your patients. So here is a study from the Princess Margaret group. They tout this as the first study that looked at clinical assessment of tumor thickness with radiographic interpretation using the MRI. You can see there's a strong correlation between path, radio, and clinical for tumors greater than 5. In superficial tumors, it has low correlation compared to path. So again, depth of invasion 2 millimeters, 3 millimeters may not be associated with a high incidence of metastasis, but you don't have a validated foolproof method to show that you are able to assess depth accurately in your clinic. And that's why probably you'll need to operate all patients. However, the corollary, if a patient has had a good wide excision, say Dr. Shah has done it, Vikram has done it, Vishal has done it, comes to me for a second opinion, I see that the depth is 2 millimeters, all margins wide, my imaging is negative. In that group of patients, I won't go as a second stage and operate the patient. I'll tell the patient there is data that we could observe you, but be regular on follow-up. And the fourth point is meticulous follow-up as touted in the ASCO guidelines, a procedure that the Netherlands group said okay for these group of patients. Patients must participate very, very strictly. And it said your patient's inability to participate in such a surveillance program and the expertise in ultrasound, probably this is not good. Let's look at this. There are two papers from the Netherlands that use what is known as the wait and watch approach and the wait and scan approach. Scan is ultrasound, and one from Hong Kong, which was a randomized trial that followed patients with an ultrasound or ultrasound guided FNAC. Again, I've not put too many details. Patients are followed up with 5 to 6 ultrasounds within 6 months in this group of patients. Look how intensive it is. But concentrate on the last column here. Look at the number of patients who came with bad factors, 9 out of 12. 89% had an MRND. 90.6 needed adjuvant radiotherapy. You may be able to salvage your patients, but instead of doing a small supraomoid dissection, you're now doing a full modified neck and giving more than 2/3 of your patients post-operative adjuvant radiotherapy as seen across all these studies, burning a very, very important treatment modality in a group of patients that are prone to a second primary and a small minority to a recurrence if you had done a neck dissection. So the 4 things, T1 not good, I showed you SENT trial. Imaging not good, I showed you SENT trial with more than 24% having relapsed despite extensive workup. Observation as in the Dutch group, not good. You just concentrate on the last column. And the 4th was how do you assess depth? No validated method. So elective neck dissection must be standard of care. 1 death is prevented for every 8 patients based on our study of 12.5% difference in overall survival. And 1 recurrence is prevented for every 4 patients based on a 23.6% difference in disease-free survival. It's also cost-effective. And here is a cost-effective analysis published in the Journal of Clinical Oncology. And these are all top-level journals I'm presenting to you today, looking at the cost-effectiveness of END on a Markov model utilizing figures from our data. This is done in the US. And as you can see, it's important in saving costs, quality of life, and its cost effectiveness and willingness to play. So the END not only saves lives, but is likely to negate costs associated with salvage treatment. I finished the first part of my presentation. Mr. Moderator, if anybody wants to make comments, I'll be delighted to take them, or I'll go to the second part, whatever you feel. If they feel they want to take the questions now, I'm open.
No, we are making a list of questions. So we have made a list of questions. At the end, we'll address it together, sir.
Okay. Now let's go. Now we know we have to operate. What should be the extent of neck dissection and what should be the role of the sentinel node biopsy? Again, literature is replete with studies on sentinel node biopsy. You just Google sentinel node and you'll get so many studies on sentinel node biopsy. Remember, this was a procedure done by the breast and the melanoma guys, and suddenly our brethren felt a little left out and jumped onto the bandwagon and started doing sentinel node biopsy. Let's see scientifically what's the role. I've put up figures of a meta-analysis and the SENT trial. Two things stand out very good with the sentinel node. It has a high diagnostic accuracy and a high negative predictive value. So if you do the sentinel node biopsy, you are good. If it's negative, the chances are that you're missing a node is very rare. And you can see here that the negative predictive value is upwards of 96%. Good diagnostic accuracy, good negative predictive value. So why don't we use the sentinel node biopsy? Is there data? Here is ASCO last year presentation from 16 Japanese institutions looking at T1N0 more than 4 millimeter. Primary endpoint was 3-year overall survival. It was based on a non-inferiority design with the difference kept at 12%. This was an ASCO presentation. It's not come out in print to the best of my knowledge. Now they randomized 271 patients, 134 in the sentinel node group, 137 in the neck dissection group, fairly robust follow-up. Look at the 3-year overall survival and relapse-free survival, non-inferior. So doing a sentinel node is safe, it's non-inferior. Look at the 1 and 3 month abduction was worse in the neck dissection group. So some compromised in function, 1 and 3 months, details not included in abstract, but I'm showing you a trend that you may be screwing up a few more arms by doing a neck dissection. But you are not improving survival, it's exactly the same, you're not compromising survival. Now, let's see how this translates into a place like the US, where head and neck is not so much of a problem and physicians have more time. So here is a study looking at between 2012 and 2015, looking at the National Cancer Database. Our friend Uma was part of this, Sandeep was part of this, basically Bob Ferris's group doing this work, looking at elective versus sentinel node biopsy, 8,328 patients with a follow-up of 5 months. So they did all their database, and you can see elective neck dissection is really the treatment of choice. 8,000 people had it, and only 240 had the sentinel node biopsy procedure. Despite the sentinel node biopsy having lesser complications. So if you look at this, completion to neck dissection avoided, post-operative morbidity with hospital stay, all in favor of sentinel node biopsy, even the 30-day mortality 0% year, 0.7 may not be statistically significant in favor, yet 8,000 elective neck, 240 sentinel node in a clinic, in a country where head and neck is, where the departments are not inundated by large numbers. And the authors conclude, despite these attributes, sentinel node remains rarely used in the United States of America. Why is this so? If you look at failure patterns of sentinel node versus END, it's more or less the same, 6 versus 6.7%. You can never have a trial. You'll need more than 2,000 patients to have a trial if you want to drive it on superiority. It has to be a non-inferiority design. But look at the others. There's a steep learning curve. Costs are much more. The procedure is cumbersome. You need a nuclear dye, serial step sectioning of your specimen. You need IHC. It's very, very cumbersome. 1/3 of patients will be sentinel node biopsy, and you'll have to take them back into the operating room to complete the neck dissection because no one knows just doing an SND if it's safe. And lastly, what is the morbidity? It's not like the limb where you have severe. I said our breast and melanoma guys who operated on the groin and axilla would have that problem, and that's why sentinel node came. Here's a classical breast patient. 54% of ladies have this kind of a arm if you do a neck dissection, an axillary dissection. 31% like that, and only 19% like this. Makes sense to do a sentinel node biopsy. Look at our patient here. Can't even make out which side of the neck has been operated. I'm going to give you all a prize if any of you all can tell me which side of the neck has been operated on. So really, if you're driving it on better output, you can't make out. There's no winging of scapula. There's no incision seam. So you need to do your neck dissection properly. And here again is Joachim Werner's group looking at 98 patients who underwent a selective neck dissection. See the complication rates, restriction of head and neck mobility, shoulder and arm mobility, 0%. So if you really do your patients well, 86.5, 96.2% of patients, absolutely no complications. Do your operation well. Don't waste your time on sentinel node biopsy. Having said that, I'm not against it. Good diagnostic accuracy, good negative predictive value. The important thing to do is preserve the spinal accessory. Don't do traction. It's not that you cut the nerve. Traction, skeletonization, and devascularization of the nerve leads to intraneural microvascular flow that is disrupted, leading to ischemia, and then you get axonal rupture and degeneration. This despite you maintaining the continuity, and the nerve is at the highest risk at level 5. So now let's see how much of operation we need to do. People say clear level 4. Bob Byers' paper, 15.8% skip metastasis. But I urge you all to read the paper. People who scored 15.8, I'm sure have never read that paper. The incidence of skip is very, very low, much less than 3%, 3 point some odd percent. And you all must read this paper in detail rather than just quote it. Whether we can avoid 2B and 5 areas that the spinal accessory is at risk. Now, here is a prospective study looking at supraomoid versus modified neck dissection, probably the only prospective study apart from the Brazilian study, which was a small number of patients. This is more recent, and that's why I put it, looking at outcomes between the two groups. So if you look at neck control rates and disease-specific survival, both exactly the same in this cohort of patients, and fewer complications in the supraomohyoid group of patients. So in all patients with the N0 neck, the operation is the supraomoid. You start doing the modified radical neck dissection, you will have an increased complication rate, which is statistically significant. And that's because you're fooling around at level 5, where the accessory nerve is very, very flimsy. Is it safe? And here is one of the studies that I take to every corner of this globe. And this is a study that Gauri led in our group, and I was happy to be part of it. I can see Pooja, Abhishek, Vaidya, some great names in the field. We did a very simple study. And again, this is to just inspire youngsters listening. It's nothing great. We did 583 neck dissection in 470 treatment naive, and here are the figures of unilateral. The hallmark of the study was after dissection, cutting it into small bits so that each level is properly labeled. And you know Gauri, she's quite a taskmaster. You can be sure that all this went very appropriately in right packets. Those of you who worked with her will swear by that. Now look at this. We had an equal number of tongue, buccal mucosa, T4 and T1, 2, 3, and about an equal number of node negative and node positive. So really truly representative of all oral cavity cancer patients. 91% of metastasis occurred at level 1 to 3, 96 from 1 to 4. So if you did 1 to 3, you'll get 91% of your metastasis. There were no skip metastasis at 4 and 5 in the absence of metastasis at level 1 to 3. You did get skip metastasis, 13.8, but if your upper neck was negative, you won't just get an isolated level 4. So going and fishing out level 4 on the left side of the neck, risking the thoracic duct when your upper neck is negative, may be an absolute no-no if you look at a properly done, validated study. Neck metastasis skip is higher in tongue cancers. What causes skip at 2B and 5? The presence of 2A nodes as well as the subsite. So 5 is most seen in buccal and retromolar when 2A is positive, and 2B is more seen in tongue when 2A is positive. So concentrate on 2A. And many people tell me, how do I know whether 2A is positive? I don't have frozen section. Honestly, it's gross 2A disease. One of the fallacies of this study was if we had known that the 2A was clinically negative, operatively negative, and then we would be more convinced to be able to say that yes, if 2A is negative operative judgment, no need of doing 5 and 2B. But I'm going to show you data that will validate the thought that I'm doing. Meta and elective versus comprehensive neck dissection in clinically node positive patients. 5 studies for 43 patients looking at ipsilateral, contralateral, and overall neck recurrence. Absolutely no difference. Look at the p-values here. So you can do a supraomohyoid even in a node positive. Review of literature. And I'm just wondering if Dr. Ashok Shah is part of this paper. No, he isn't. Dr. Jatin Shah is part of this. The Alfie of Farlito group looking at selective neck dissection using the PRISMA guidelines of all published literature of selective in head and neck patients. From the reviewed literature, selective neck dissection is a valid option in patients with CN1, select CN2, which is non-fixed nodes, absence of palpable metastasis at 4 or 5, large nodes greater than 3 centimeters or multiple levels of node. So I go back, supraomoid for the node negative neck, there is some role to do a supraomoid even for node positive with small volume disease as seen from this study and the meta-analysis that I showed you of 5 studies of 443 patients. What do you do to the opposite neck? And here again, the ASCO guideline says T3, T4, or when they approach the midline. So T3, T4, tongue, floor, mouth, 25 to 40% contralateral metastasis, do the opposite neck, even if it's imaging negative. But here is another study that we did, and I will look at it and I'll quickly go through it. When you look at 273 patients between 2007 and 2010, again led by Pooja's husband Vikram, Sudhir was there, Deepa was there, Pankaj was there, I was there. We looked at the incidence of contralateral metastasis. It was 29%. But it was never there if the ipsilateral neck was negative. So you can see that if the ipsilateral neck is negative, there's a 97. So of these 29 patients, 97 had ipsilateral nodal metastasis. So if ipsilateral nodal metastasis was not there, you'll never get a contralateral. So again, a message for y'all, if a lesion is approaching the midline, don't hit the panic button if the ipsilateral neck is negative. And I'm going to end this section of my talk that your neck dissection has to be very, very well done. A minimum of 18 nodes should be dissected. Those are recommendations for both the N0 and the N plus neck. So it's not only surgery, but even your pathologist must harvest 18 nodes and study them because that is related to good outcome. Here is again NCDB database that if you had cut margins negative and more than 18 nodes, it translated into better outcomes. So quality of surgery, very, very important. And Ibrahimi, who's done a lot of work on statistical jugglery, the depth paper he led as well with the international consortium, again showing that 18 nodes is a cutoff for this group of patients. So youngsters, when you operate, it's not about doing an SOHT in 20 minutes and running to the next nursing home. It's about harvesting at least 18 nodes, both by you and your pathologist. Do I have time for this last section or should we skip it, Vishal?
No, sir. Please go on, sir.
Okay. The neck in chemo radio. I hope there are guys still listening to us and not vanished.
No, the bandwidth is not good enough, sir. There's so much of people who've entered now.
Okay. The neck in the chemo radiotherapy setting. Now, there's always been this debate on the management of the N2, N3 node. And I want to share with you all a little philosophy so that you all don't get confused how to treat the neck. When the VA trial came, and I'm not going to spend time on the VA trial, youngsters who don't know it, it was induction chemo followed by RT versus surgery, RT in larynx. They noticed that 92 patients had N2, N3 nodes. 46 in the chemorads arm, and those patients in the chemorads arm did poorly if they didn't achieve a CR. So the RTOG study started doing a planned neck dissection 8 weeks after chemo RT, because by then the science had moved forward from induction to RT to concurrent chemo RT. They advocated a planned neck dissection 8 weeks later. But then things had changed. We had CT-RT now instead of RT, better control rates. We had the PET that could address the better response, and changing epidemiology of P16, not associated so much with ECS, various other problems. So the philosophy changed and planned neck dissection went out of the window, because people said it's unnecessary surgery in patients with a complete response. There's no proven regional control and survival benefit. And neck dissection in a post-CT-RT setting is associated with morbidity. And imagine then going in 1 or 2 years later to do a laryngectomy after a neck dissection. My God, it compromises later survival. By then, the science had moved, and Farlito's group again looked at chemoradiotherapy and said it's a concept approaching obsolescence. They looked at 50 studies, 24 for, 26 again, and they found all the 4 were older studies, did not ascend response, surgery at different time points, and the science had already moved. But our dear friend Hesham had already started his study, so he continued it, and it got published in the New England Journal of Medicine, which is very distinction to have a surgical study there. So basically what they did was, when they looked at neck dissection versus neck PET surveillance, the curves were overlapping. Overall survival didn't make a difference, telling us that PET neck is okay. What happens to patients with an equivocal scan? And an equivocal scan is defined as structural node but no uptake, or uptake but no node. And this data I've got from Hesham. I don't think he's published it. There were 45 patients out of his 270 who had the PET. 11 were outside the neck, 34 in the neck. Equivocal scan, structural node, no uptake, uptake, no node. Now see what happens. Abnormal scans in the neck, 50% positive. Equivocal scans, 50% positive. But as you break it down, you will notice that an abnormal PET uptake, normal node, nearly 50% of nodes positive, 21 numbers small. And then when you have no PET uptake and abnormal nodes, again 50 are positive, but they're only 2 patients. So these numbers are too small to make a firm conclusion. But remember, when you have an equivocal scan, there is a possibility that 50% of patients will harbor disease in the neck node. And you can see this translates into inferior outcomes, but they're much better than those that had an abnormal PET scan. So they're better, but definitely different from those that had no equivocal and no abnormal PET scan. Now everybody asks in every panel, is this paper okay? Can we use it for large nodes? Can we use it for non-oropharynx? Look at oropharynx, 85.1%. Look at large neck nodes, 18 plus 3, 20%. So can we use it in N2C, N3? These are such small number of patients. N2, N2B was a large number of patients, but they were oropharynx. Let's see what we can do. The crux of chemoradiotherapy and salvage depends on recurrence rates. If you have a complete responder, the recurrence rates is less than 5%. And I've put up a whole load of studies and you can go through them. The majority are less than 5%. And now we have the PET scan that can tell us that whether you have got a complete response. First meta-analysis of Hesham Mehana's. Look at the negative predictive value in the neck, 97%. Very, very accurate. And this is not looking at oropharynx only from this trial. This is pooled meta-analysis data. You don't believe something from overseas? Look at our data that, where is that? Sorry, it's not. Yeah, here is our data from Tejpal and JP's group. Again, negative predictive value 95% if you do it more than 12 weeks later. Again, looking at all head and neck patients. So there's absolutely no reason for you to get panicky. Do the chemoradiotherapy, do a PET assessment, no complete response, you're absolutely fine. Now look at chemorads versus upfront surgery. Operating on a large node pre-operatively results in increased complications. Imagine an N3 node, it might be a radical neck dissection. You might have to resect the sternocleidomastoid, the jugular, and it delays definitive treatment in contrast to a super selective neck dissection, which you can do post-chemoradiotherapy. Tolerance to chemoradiotherapy is poor, as sometimes the SCM and the jugular need to be removed. Imagine the carotid pulsating below your skin flap and you have to give 7,000 rads to cure the primary. And salvage surgery has not been found to be inferior to upfront surgery. Plus, we have the PET scan to pick up the complete responders. Those less than 5% who don't have a response need to go for upfront surgery. So I told you, evidence plus logic as well. And you can do a super selective neck dissection in these patients, a concept brought up by Robbins, and I don't want to spend much time on this, but just for completion so that the youngsters can go Google that if you can only operate the benign discectomy, the N3 node, if that's left behind, only take it out. Only one patient had a non-contiguous nodal involvement in this study and their subsequent publications. So I'm going to end. The clinico-radiologically negative neck N0 must be treated electively. No place for depth, no place for T1, no place for imaging. I've shown you all the data. The extent of neck dissection is the SOHND in the majority of patients, except for large bulky lesions. And the neck in the chemoradiotherapy setting is logically and with science treated by salvage. I don't have time for adjuvant imaging and molecular, but I'm sure Vishal and others, I think Sean covered the imaging in a previous module and Sarbani or someone's doing adjuvant. So you all will have a lot of controversies in those subjects as well. So thank you once again, folks, and thanks Vishal for this wonderful opportunity to present. And I just hope it was useful. I'll be delighted to take questions.
So thank you very much, sir. As usual, you have kept us on the edge of our seats. We've all been completely glued to this presentation. Thank you so much. So we've got a whole list of questions. I'll just quickly tell you those questions, sir, and then you can pick and choose.
No, you just tell me one by one, because I tend to forget, and maybe some of the people who are part of my trial, if you can unmute them, if they want to chip in with any data and any other data, Harsh, Richa, Gauri, all of them, Devendra, whoever is there, if any of them want to chip in, they're most welcome.
Sure. So, so a couple of points. Of the first, some of the basic questions is, what is a radiologically N0 neck? I think those questions you have answered in your slide. How do you manage verrucous carcinoma with N0 neck?
Okay, so really verrucous is not part of this topic, but it's a very interesting question. So verrucous carcinoma has a low propensity to neck node metastasis. Actually, they say that the incidence of nodal metastasis is very, very low and you don't have to operate the neck. But however, when you operate a verrucous carcinoma, usually two things happen. One, you're raising a cheek flap to access the lesion, unless it's something very small anteriorly that you can do per oral. So about 6, 7, 8 times out of 10, you'll raise a cheek flap, and it's safer to do the neck. Because when the final histology comes, about 10 to 15% of patients have what is known as a hybrid carcinoma. Within the verrucous, you will have areas of differentiated thyroid cancer or squamous cell cancer. And then if you've not done the neck, to go back again and do the neck will be a disaster. So if you're operating a verrucous and you're operating via a cheek flap, it's safer to do the neck, because you will have a significant percentage of patients who will have hybrid carcinomas in this group of patients.
Sure, sir. Thank you. Another question was...
what is a radiologically negative? Yeah. Go ahead, Vishal.
was on elective neck irradiation versus elective neck dissection. What are your comments on that?
Oh, this is a very, very important elective neck radiation. You know what I suggest this question be taken by the radiation oncologist. But here's what I'm going to tell you. I'll tell you very, very simply. Remember that oral cavity is a surgical disease. So if I operated a patient with a T1, T2 oral cavity lesion, I do a small wide excision per orally. I operated the neck and I send the patient home in a week. There's more than a 70-80% chance that the node will be negative. I don't need adjuvant treatment. Contrast this to wide excision of the tumor radiating the neck. 6 to 8 weeks, I can't go back again and give the patient radiotherapy. I've already done it once. God already gets a second primary. He gets fibrosis. He gets other complications, maybe ORN in the long run. So just use your head and tell me which one would you prefer. I would prefer a wide excision, quick neck dissection, go home, rather than wide excision and elective neck radiation. However, if I'm treating the primary with radiotherapy, then if there's an increased risk of nodal metastasis, I'll give radiotherapy. And that will be for all subsites in the oro-hypolaryngopharynx, except the T1 glottis, where the incidence of metastasis is very, very, very low.
Okay, sir. So somebody has asked us about elective neck dissection for suspicious looking precancerous lesions or unproven cancer. Would you recommend that?
No. So remember, there are 5 prerequisites of doing a neck dissection, and I'm not going to make this sound like an MS lecture. The first one is that you have proven metastasis in the node and the primary is controlled or controllable. You only do a selective neck dissection in variance to this basic tenet of a neck dissection. And the selective neck dissection is more to prognosticate. So you'll get important details. So if the nodes are positive, there's ECS, then you can give the patient adjuvant treatment. So even if you look back at our trial, exactly the same thing happened. The elective neck dissection patients, a large number of them, we were able to triage. We were able to pick up neck node positive. We were able to pick up microscopic ENE. Patients got radiotherapy and they lived. 81% of patients lived with T1, T2 as compared to 67.5% if you gave the radiotherapy later. So I believe that it is beneficial and it helps patients.
So can gross palpating of the tumor thickness predict neck nodal metastasis like the depth of invasion?
So I made that point. You really have to be God's gift to mankind to be able to do it. If an MRI can't do it, remember that the depth is from the basement membrane to the deepest point of invasion. You have to draw a line on the slide by the pathologist, and then using a 4X scanner, they calculate this depth under microscopy. And now I'm going to tell you, if we looked at every millimeter increase in the depth in our trial of 500 patients. So from 3 to 4 millimeters, metastasis jumped from about 4% to 15%. Imagine at a thin level, how accurate will your finger be to be able to say 3 millimeters and 4 millimeters? A non-head and neck pathologist will not be able to tell you accurately. But again, to answer your question, one of the secondary objectives of our study was to do a correlation between the on-table, that means you bisect it on-table, frozen section, and then look at final histopathology. On-table and frozen for thinner lesions did not correlate with final. The concordance wasn't as good as for thicker tumors, exactly in the Almeida and Ralph Gilbert's paper from Princess Margaret with MRI. So for thin lesions, a 1 millimeter jumps the percentage of nodes by 10-15% and detriment in survival. So I will not base it. If God has gifted you with really, what should I say, blessed fingers that you are able to look at a lesion and say 3 millimeters, 4 millimeters just by touching it, so be it. And also remember, tongue lesions are very, very painful. You try to squeeze a tongue lesion, 5 patients out of 10 will probably slap you or wince.
And what is your preference for neck imaging? And is there any role for intraoral USG?
So there is a meta-analysis looking at MRI to intraoral metastasis. I should have put it up. I probably have that literature with me as well. I think there were 8 MRI studies and 12 intraoral. They showed that intraoral ultrasound is more accurate, better than the MRI. But I mean, you just have to again extrapolate doing an intraoral ultrasound for a patient who has a lesion in the mouth. You have to put that probe, it's wrapped in a condom with a whole load of water in it. It's shoved into the mouth to get depth. And again, for thinner lesions, whether you're plus minus, and it's only validated then in cases of tongue cancer, there's a lot of subjective variation in doing these procedures. So much easier to just operate the primary, do a quick supraomoid dissection, save lives, and it's cost effective. So I don't really think we need to do all these things. You do an investigation. Now, supposing my patients were going to get severe lymphedema, like the 50% of patients who had the breast cancer with that big swollen arm, in that case, I would go for all this. If I have 0% problems, I can do an operation within 10, 15, 20, half an hour, 45 minutes at max. I can save lives. Why do you want to keep doing this intraoral ultrasound? There's absolutely no benefit in doing this. So it's not in my book to do it.
So institutes with long waiting lists for adjuvant RT perform neck dissections, R&D instead of mRND in N plus necks, your opinion?
What's saying R&D over mRND?
Yes, sir. In N plus necks, your opinion?
No. So listen, R&D died long time back. It continued well into the 90s, but according to me, it should have been buried in the 50s when Bartlett and Callender first showed that it is equally controllable, and Boca's work then showed that it was very good. So tell me, why should you do an R&D? Again, I told you, common sense, biology, principles, evidence. Why should you do an R&D? Take out the sternocleidomastoid, take out the accessory nerve, take out the jugular, leave back the carotid, leave back the hypoglossal. Where is the facial plane that is different between these three? And remember that if you remove the accessory nerve, patient gets what's known as a drooping shoulder syndrome. 90% of patients can't do simple household tasks of putting things in the shelf in the kitchen on top, raising their hands. 40% of patients, and there's a classical paper by Schoen and Yardley, 46% look for a change in job because of accessory going. So if you're too busy, please don't do a radical neck dissection because of time. There's some of us out in private who have a little more time, and we'd be happy to help you all if you all are very, very busy.
Okay. So then, apart from depth of invasion, what are the other clinico-pathological questions that can predict nodal dissemination according to you?
Oh, so there are many things. Now, this will be a talk on its own. You can do a module for me just on predictors of nodal metastasis. So if you want histopath features, apart from depth of invasion, the T size. So the larger the T size, more the probability, depth, and the last is the grade. Perineural invasion is also known to be associated, or aggressive factors, perineural, lymphovascular invasion, grade. These all signify a biologically aggressive tumor. In addition to that, there have been various molecular markers that have been studied. And if you all Google the Ropeman paper, he's done a gene expression classifier and looked at validating and predicting metastasis. And our dear Sudhir, if he's there, he can tell you today's his birthday. You all can sing happy birthday to him as well. Sudhir has done something on MMP10 and did show some kind of increased overexpression and prediction to metastasis. But all these are all lab work. They've not come into standard treatment.
Do you recommend 2B to be addressed routinely, or is there any place where you can exclude it, sir?
So I told you, really 2B is only when you have 2A nodes. But having said that, there is no clear demarcation between 2A and 2B. It's just in and around the accessory nerve. So what I tell people, if your neck is truly node negative, radiologically node negative, clinically node negative, on operation you find it node negative, I clear 2B, but I'm not chasing that last globule of fat in the supra-accessory area and pulling on the node, getting my assistant to put a vein loop. I don't do that. I just clear the fat grossly, because if you look at all studies, the average number of nodes that can be harvested in that area is 3.2. But if you look, when you operate, the supra-accessory, really when you take out, it's only fat. They're never nodes there unless you're operating on an N3. So clean it, but I explained you the pathophysiology of screwing up the accessory nerve. It's basically traction, intraneuronal blood flow. It's not cutting the nerve. So do it gently, and at the same time, no traction, and don't use diathermy. You're fine. Use sharp scissors, and it's good in COVID times as well. You have less aerosol, and then just use a bipolar cautery, and I do it that way.
Thank you, sir. So, in this era, is there a role for brachytherapy in early oral cancers?
Yeah, now this is again off the neck, but I will answer it. So when you look at T1, T2 cancers in the oral cavity, control rates with surgery and brachytherapy exactly the same. T3, T4 surgery scores over radiotherapy. You always do surgery first. Having said that, if you do brachytherapy, you have to give external beam brachytherapy. I have to give external radiotherapy to the neck in the vast majority of patients. Surgery, in contrast, is simple, it's fast, it's cost effective, it can be repeated, and even dodos like me can do simple, good surgery with wide margins with no functional and cosmetic deformities. Contrast it to radiotherapy. You need a sophisticated machine. You're not going to treat your patient on cohort with all side effects. You need 6 to 8 weeks. You need, you've burnt a very important armamentarium. You're not going to use it. So in the oral cavity, I only refer for brachytherapy for lip lesions, particularly if the commissure is there and it's very superficial disease, or occasionally on the palate without bone erosion, where they can do surface radiotherapy, mold radiotherapy, what they call. And if there's any radiation oncologists, they could give you all the details. I would be happy to give you the details of mold radiotherapy and brachytherapy, but I guess it will be blasphemous for a surgeon to do that.
Sure, sir. So we have some last few questions. I must tell you, we had 400 plus participants. So we have a long list of questions, but we are almost in the last few of them. Somebody has asked us is how to address the functional difficulties that arise of lymphedema in salvage neck surgeries.
Head and neck lymphedema is a very, very important aspect. It's an unrecognized and an aspect that very few of us as head and neck surgeons really give importance to. Now, in this short period, it's very difficult for me to explain you how to treat lymphedema. It has to be treated. I will draw your attention to two quick references, which I guess y'all can read and learn how to treat. One is the MD Anderson with Jan Lewin's group writing on lymphedema, but basically the lymphedema of the head and neck is treated by various types of maneuvers, and these maneuvers were first described by a man called Wooder. They're called Wooder's maneuvers. And then many people have gone and developed on this towards head and neck. So it's a combination of preventing lymphedema by doing surgery in the right way and needlessly not tying up every vein that you could save. Whatever you do for lymphedema to prevent in axilla and groin and various other things, Your radiotherapy technique should be good, and you should give good radiotherapy where you don't have that woolly hard skin and lymphedema. And lastly, you do these Wooder's maneuvers, and various other kind of drugs have been described, including trace elements, which you will get in these papers, and I just suggest you all read them, because again, this is an entire topic. I did refer to this briefly at one of my panels that I did. I don't recollect where. I think it was with Shamit. He did a lovely program on mitigating morbidities of head and neck, and I did kind of share some views there. But I'll be happy to take this offline. It's a very detailed answer to give in this short period of time.
Thank you, sir. The other question is that you didn't speak about anything specific on HPV. Is there any role for HPV to be considered in management of the neck?
For HPV?
Yes, sir.
So HPV and neck is different. I probably did not speak on HPV because HPV is not a disease that has come to this part of the world. You all must realize 2-3 things. I'll make 2-3 comments about HPV. Again, draw your attention to the 8th edition of the AJCC. The neck node staging for HPV associated oropharyngeal disease is different from neck node staging for the rest, which is less than 3 to 6. So it's a different staging system, and there's a different staging system for HPV oropharyngeal for clinical and for pathological. Clinical is based on the number of nodes, and pathological on the other pathological criteria. The last point I want to make about HPV, when you treat them, resolution of nodes may take longer than in conventional radiotherapy. So there's a temporal relationship between the response to HPV nodes as opposed to the others. There's a difference in that. And I just think, again, a very, very detailed question. Maybe you can do a module on HPV.
Sure, sir. Any comments on soft tissue deposits in the neck?
Post-surgery or pre-surgery?
This is pre-surgery, sir. Anything about predicting? This is a generic question, but I think you can address it broadly, sir.
No, but I'll tell you, generally soft deposits usually come after surgery. Do your surgery meticulously, but in patients who have multiple nodes, perineural, you usually get a soft tissue deposit. Very, very difficult to salvage. It's usually in and around the carotid bulb. You go in and operate, you can't get wide margins, you can't even give them radiotherapy because the carotid is there. You can't even put in brachy wires because you'll have a carotid blowout. Maybe out of 100 patients, less than 5, we go in and excise the soft tissue thing, and then with the radiation oncologist put brachy wires across after covering the bed and seeing that the brachial plexus or the carotid is shielded away from the wires. But I know if Sarbani is listening, I don't know, she might get wild with me. She would come into the operating rooms, but out of 10 cases, 9.9, she would run away saying carotid is at risk. So really, it's very difficult to salvage these patients.
Thank you, sir. And role for diffusion-weighted MRIs in detecting neck nodes?
So again, diffusion-weighted MRIs has been done. There's been the iron oxide, diffusion-weighted MRIs, various things, PET in the N0. There are studies that show that diffusion-weighted may have some benefit, but again, it's not standard of care. It's not something that we use all along. Again, this was something that probably Sean and others should have covered in the imaging module, but I have some good compelling data of the various meta-analysis and the various modalities predicting sensitivity and specificity of nodal metastasis. But I'll answer this question very simply. People have showed some potential role of diffusion DWI, but it's not standard of care.
So do you recommend considering patterns of invasion for adjuvant radiotherapy?
Yeah, that's another very, very long question that we have to do there. These are known as intermediate factors, and I'm showing who's doing your module on adjuvant, Sarbani? Vishal?
Akshay, I'll have to just check who's doing it, sir.
Yeah, I think it's Sarmani. Sarmani will cover these. Please remember, there are some definite indications for radiotherapy and there are intermediate indications for radiotherapy. Maybe I can draw your attention to a review article I've written with Richa and Harsh, and it's in Oral Oncology. It's in 2018. It's a very, very good review article, and then we've done a special issue on oral cancers in general where we have covered locally advanced. Sarmani has covered early where she also talks about this. We've covered it a bit. Gauri has done neck in that. So if you can give me the numbers or the contacts of these people, either pass it to Harsh or Richa, two people who work with me, and they would send them all these things. They'll get all the answers there. Because this is not a very simple answer for me to give in a minute. It will just eat into other people's times. We can just
Do you
answer this offline.
What do you suggest about planned neck dissection in the salvage settings?
I told you that it was only done after the VA trial, but then things have changed with CTRT, better control, with having PET neck, better picking up complete responders. No one does a planned neck dissection anymore. No one does it. No one does it. And no one does a pre-op neck dissection either.
Somebody has asked you, should we routinely remove the tail of the parotid in neck dissection?
Yeah, you can. Many people used to remove the tail of the parotid, but remember one thing, usually I don't remove the tail of the parotid, particularly if you're operating on elderly people. The reason is that the gland is toast in a large number of patients. So when you start removing the tail of the parotid in an elderly man with a toast gland, you suddenly realize you've removed more than half the parotid. You're into great substance. You're hitting the mandibular, the vein. It's bleeding like hell. You're damaging sometimes the entire marginal mandibular nerve right there. And really no advantage removing the tail of the parotid. But having said that, if the patient has a lesion that's coming into the soft tissue of the cheek, lip lesions, other things where I feel there may be a little bit of spread there, I do remove the tail of the parotid. I look at the parotid nodes, but I do that on pre-operative imaging.
Sir, Doctor,
I can see Rajendra Toprani, my dear friend, saying the role of FNAC in equivocal neck responses. And I would love to answer this, but again, Rajendra, it's a very, very long answer. It's a multifactorial. You have conventional image signs. And I think I shared all this on the FHNO symposia. There are various criteria defined on radiology, on ultrasound, with sensitivity varying from 40% to 70 odd %. But really the FNAC is very difficult. But there are two things that will guide you. And again, I'm not going to discuss in detail. One is looking at ghost cells. Ghost cells are classically described by a pathologist. If it's a ghost cell, they're non-viable, and you confirm it by doing a Ki-67. So some people have shown that if you do Ki-67 stainings and it turns positive, then in those cases, you should operate in the equivocal neck. But here's what I do. I just follow these patients very, very carefully. Unless I feel like it's restricted mobility and it's going to get fixed. But yes, FNAC has a limited role because of post-RT changes. And if you want to really base yourselves on that, you have to have a good pathologist and train for, same for Ki-67 as well. I think there's a paper, now I forget who the first author is from Memorial. I think Ian Ganley has done that. You can again Google, or I can send you that paper.
Sure, sir. Sir, what do you recommend doing SND for node positive necks?
I've said all this. These guys who are asking me these questions have tuned in late. Yeah, I showed you the meta-analysis of 443 patients. I showed you the Prisma analysis of.
So for those, I think we have this,
you can do an SN.
Yeah, we'll be putting this lecture on YouTube, so they can all go through it again and refer to it.
I hope you had told me this YouTube business. I've not shared.
No, sir, you're looking cool, sir.
Listen, I want to look professorial.
Okay, sir. The last question, sir. The rationale for doing the neck first and then primary versus the other side. whether
Oh,
you should do the neck first or the primary, or the neck later after the primary?
I always believe a very, very good question. Theoretically, we don't have data to tell us whether you should operate the neck first or whether you should operate the primary first. In fact, the concept first came from colon cancer, and it's known as Turnbull's no-touch technique. So Turnbull was a man who popularized that if you start manipulating the primary, you will be showering tumor emboli into the lymphatics, which will go and seed and probably go into the liver and various other things. So what they started doing was first going to the pedicle, clamping the pedicle so that then when you manipulate the primary, there's no shower because you've already disrupted the blood supply and all the lymphatics that come to that blood supply, the lymphovenous channel. But there was absolutely no difference in outcomes with the no-touch technique. So even in a place where the lymphatics are so well defined along the mesocolon, there's absolutely no difference. But now look at it again, I said logically. When you operate a neck, you open the neck. You've assessed operability with an N2, N3 node. You know that it's off the carotid. You've got control of the external carotid artery. God forbid you have some torrential bleeding from the tongue, something retracts. You've got control on the lingual. You're able to harvest the facial vessel nicely for your plastics to do the microvascular free flap. You raised a beautiful cheek flap, and now you're going to excise the primary. It's so much easier when you're cleaning into the infratemporal fossa. You can keep seeing the carotid, putting your finger on the styloid process. I feel more secure than just going and hacking out the primary. Imagine if I'm doing a tongue lesion, I have access to the neck. It's so much better to assess the third dimension of excision. I can do a compartmental excision. I can feel the tip of the hyoid every time I'm dissecting, take the hyoglossus off from there, detach the entire thing as one group, then operating per only and pulling the tongue into the mouth. Here I can do a combination of both. Same for floor of mouth. If I want to do a marginal mandible and I've raised the cheek flap nicely, done the neck, specimen hanging on the neck. But the point that I make and I want to tell you is that I always keep the neck specimen in continuity to the primary. And that's an important point that I would tell you. Whether you take out tail of carotid, whether you do this first or that first, this to me logically is easier doing the neck first. I have better control, but I always keep the primary and the neck in continuity. And I think Deepak Sarin's group has shown 6 to 8% of buccal nodes positive. You operate the neck separately, then you come and do the primary. In between, tissue may be left. I always advocate one piece altogether. Guys who have worked with me will always tell you that I do it that way when I did the neck.
Thank you, sir. So I would request Dr. Ashok Shah to come in and speak a few words, sir. I mean, this has been a very good forum for us. We've had 400 plus participants across through the entire session. So I think it's been a completely, for us, it's been a completely...
Vishal, very humbly, if you had advertised that Dr. Shah was coming, there would have been 1,000.
Well, I sincerely enjoyed. Anil, as usual, you did a great job. This is a very complex subject. You tried to make it analytical, and your work is extremely well quoted all around the world. Nobody can give a talk on neck dissection without quoting your work in New England Journal, and probably one of the few publications in New England Journal from India. So congratulations. I think the subject is quite interesting, and I think the gist of your talk was use common sense, use your judgment, and do the best for your patients. So I liked when you said radical neck dissection is a dead operation. I think that is very appropriate. The one thing I just want to point out, the tongue cancer is a much different disease, much more aggressive than the lip cancer or the hard palate or the soft palate. And you need to be very careful when it comes to tongue cancer. The general consensus is T1, you don't need to do the neck. But keep in mind, about 30% of the T1 tongue cancer will have nodal disease. And if you don't do anything to these patients, salvaging these patients may be very difficult. And sometimes we get emotionally attached to the patient, especially a young girl with T1 tongue cancer. Those are the worst problems. Be more aggressive. And I think the being surgically aggressive with appropriate neck dissection is more rewarding to the patient and to the physician. Again, enjoyed the talk, wonderful, and I'm very happy to see
Thanks,
a huge crowd.
And give my regards to all my friends at New York, sir.
I sure will.
Thank
Thank you, sir. I think we can close the session now, sir, and we'll be putting this video up on YouTube, and we'll send you the links, sir, so that you can send it to more people.
Okay,
Thank
thanks, Vishal. Thank you
Good day
so
to you
much
all,
for
sir.
having me. Proud of you and all that you've achieved. Thank you.
Thank you. Good day to you all, sir.
Thank you.
Thank you, Ashok sir. Thank you very much for coming in. And all our friends and colleagues who have joined in. Toparani sir, thank you very much. I can see Mayuri there. So many of my friends, all of them there. Thank you very much for actually sparing your time and encouraging these sessions. Thank you. We'll keep you posted on the future lectures, sir. And we'll request Ashok sir, I'll write to you separately. We would want one exclusive session from you whenever you give us some time, sir.
Just let me know. Happy to help.
Thank you, sir. Bye, sir.